Presenter Rowan Chlebowski, research professor in the Department of Medical Oncology and Therapeutics Research at the City of Hope in Duarte, California. And his topic, weight change in postmenopausal women and breast cancer risk in the Women's Health Initiative Observational Study.
Thank you. And I'm presenting this on behalf of the Women's Health Initiative investigators. Here's my disclosures. None of these have to do with this presentation. The background, I think, is very interesting and important. Obesity for several decades has been recognized as a strong risk factor for postmenopausal breast cancer. However, studies of weight loss and breast cancer provide inconsistent results. And as a result, the International Association for Research on Cancer, it's a well-recognized body, authoritative body, who published in New England Journal of Medicine just a few months ago their summary, and the current public health message is now limited to avoid body fatness. So that suggests that if you're overweight or obese, it's too late to make a change to show benefit. So our study objective was to evaluate associations between weight change categories and breast cancer incidence in postmenopausal women participating in the Women's Health Initiative Observational Study. Secondary analysis explored the association of weight loss and breast cancer incidence by weight loss intentionality. The participants in the Women's Health Initiative participants were working in the Women's Health Initiative Observational Study that incorporated 93,676 women postmenopausal, age 50 to 79 years of age, with anticipated 3-year survival, recruited from 40 U.S. clinical centers from 1993 to 1998. And the follow-up will be 11.4 years after our last body weight measurement through September 30th, 2015. And we have information at baseline on a variety of endpoints. We start with 93,000 women, but actually we eliminated some women who had cancer at entry. Some of the participants had missing data, so we're left with a cohort of 61,335 women. This is an observational study, so there was no intervention. We're watching these women as they go on in their normal daily activities. Our measurements were measured height and weight at baseline in year 3 and calculated body mass index. And we prospectively developed weight change categories, which would be weight stable, less than equal to 5% body weight change, weight gain of 5% increase, weight loss 5% decrease. We took the 5% decrease because this level has been shown to change some biochemical markers potentially associated with cancer, has also been shown to prevent, in a different study population, a randomized trial, reduce the frequency of diabetes. And then at year 3, we ask an additional question. In the past 2 years, did you gain or lose 5 or more pounds, yes or no? And was the weight change intentional or unintentional? So I think the unique thing was we have a very tight window of weight change over a 3-year period of time. So compared with women with stable weight, women who had a greater than 5% weight gain were more likely to be younger, black, and heavy smokers. Women who had greater than 5% weight loss were more likely to have high BMI, but were less likely to be physically active. It's kind of almost a paradoxical population. Interestingly, the body mass index of this group was 29.9, so then the verge of going into obesity. And so we wondered in retrospect whether that was a motivating factor for them. So here's the distribution. You can see the stable weight of the group was 41,139. That was the largest group. Weight gain was a substantial 12,021. And you can see the weight loss by intentionality was either 19.6 pounds or 16.9 pounds. So that's just a substantial weight loss. We're not going to show the data, but we did have self-reported weight at year 6, and it looked like about 2 pounds of the weight was regained in both categories. So here's our main analysis. Weight change in breast cancers. There were 3,061 breast cancers among the 61,335 women in multivariable adjusted analyses compared to women with stable weight. Women who had 5% weight loss, that's 8,175, had a significantly lower breast cancer incidence with a hazard ratio of 0.88, 95% confidence intervals 0.78 to 98, p-value 0.02. Adjustment for mammography frequency did not alter findings and remain statistically significant. Women who gained weight did not have an increase in overall breast cancer, but there was an increase in triple-negative breast cancer, which we really don't have a good explanation for. And then here's the data looking at weight change and breast cancer incidence, including by weight change intentionality. And what you can see is that there was the statistical test between intentional and unintentional weight loss group found no significant difference. This finding, and the question was the weight loss by intentionality, that one question, adequate way of determining that factor? We had published in JCO earlier this year that weight loss that was intentional resulted in greater reduction, lower incidence of endometrial cancer, and we didn't see the same thing in this result. So summary, in a large prospective study of postmenopausal women, compared to women with stable weight, women with weight loss of really only 5% were at lower breast cancer risk. There's no significant difference in breast cancer findings by weight loss intentionality. These findings suggest that interventions in postmenopausal women designed to generate weight loss may reduce breast cancer risk. I feel these are very optimistic findings in that they provide a lesson to postmenopausal women that even a moderate degree of weight loss may be associated with health benefits. So I think this is kind of a relatively new finding, and I think should have public health implications. Thank you.
Let me start with the question. Rowan, do you think the reason that women who gained a little bit of weight didn't have an increase in incidence is because they were already overweight?
Yeah, I think, when we go over all these very complex mechanisms and the different drivers, I think there's probably a threshold, so obesity being associated with inflammatory factors, so I think that's a driver to a certain degree, but then something else takes over, or maybe the main driver takes over and overrides the concern. So I think we don't have enough data to decide exactly what that threshold is, but I think that's the ongoing hypothesis.
Marisa Weiss, breastcancer.org. This is really very important practically in the clinic, because clearly if you see somebody and between the visit now and the next visit, they could realistically set a goal for losing 5 pounds, and you could actually set that as a goal as you could for taking your medicine for that period of time. It could be just as useful. So this has got great practical utility. But also, just for breastcancer.org did a really interesting survey. We asked, conducted a national survey asking women identify women who were interested in lowering the risk of breast cancer and what they'd be willing to do. And we had a number of steps and asked them, would you be willing to do this or not, and what was your inclination? And most of the women were interested in doing exercise and eating better to lose weight, because they've been doing it their whole life and they figured they're going to keep on doing it almost by default. Mm-hmm. But the one step in the list of things we asked them about that they were least willing to do was modifying their alcohol use. Okay. So of the women who identified themselves as being interested in lowering the risk, only 12% thought that they would be, said they'd be willing to consider reducing their alcohol use. And so, so your paper is particularly useful because it will give them something that they say that they're interested in doing, and we as doctors also need to help them accomplish that, and it's meaningful. So thank you.
Thank you.
Rowan, is there a relationship between being overweight and alcohol consumption in your study?
There wasn't. So they seem to be independent factors,
Michael Smith, MidPage Today. In the group of women who lost weight, did you stratify them by their original weight category, obese, overweight, normal? And was there any difference in the benefit depending on that?
So prospectively, when we set up this analysis, we looked at 4 subgroups, and by age 70 or over, by prior menopausal hormone therapy use, and by body mass index. And it looked like there wasn't a difference. And interestingly, that stable weight group, had the same relative benefit as the overweight individuals did. So it looked like there was, as much as you can get from a subgroup analysis, it looked like there was no difference by group.
I think this is going to be helpful. I hope you can present this to general doctors rather than oncologists, because those are the ones seeing normal women by and large. But in my patients, I've always suggested that they lose weight. Most of them are overweight, to be honest with you, with breast cancer, it seems. And I always had to do it because of diabetes and other factors. Now we can do it because we have a breast cancer endpoint that also suggests that losing weight will help with that as well. So I think this is an important observation.
Yeah, I think the one thing we had a meeting talking about implementation kind of yesterday, and I think the idea is that reimbursement and who's going to do it is an ongoing concern, right? I mean, in terms of kind of funding for doing it, certainly oncologists do not get any money for encouraging this or taking any steps to implement this. So that's another battle that needs to be conducted.
Yeah, what he's saying is that insurance doesn't pay for very much, if anything, for consultation with a dietitian to lose weight.
Yeah.
And even though it's been known to be a risk factor for many diseases for how long? Ever. Forever.
Yeah.
Other questions?
Okay. No.
One more.
I would say that the greatest stakeholder in this is the patient,
Yeah.
and there are sometimes incentives built in for her to lose weight. So she may get a reduction in her health premiums, and she may get at work. There are a number of different incentives that may motivate the greatest stakeholder to get to and stick to a healthy weight. I have in my clinical setting a medical textbook that weighs 5 pounds, and I will actually hand it to a patient and say, why don't you hold on to this book for a minute? And then they'll go, this is kind of heavy. And I say, well, yeah, and that's exactly how much weight we need to have that you're carrying, extra weight you're carrying around, that we could just put down on the counter right here, and it would make a meaningful difference. So that sort of physical example kind of is disruptive and does
I use
motivate.
a 20-pound backpack.
You do?
A 5-pound book.
Okay.
That you have in your patient room. That's great.
Okay, thanks.